Hello, everyone. Welcome to our ultrasound webinar, featuring new insights on how to examine hepatobiliary and pancreatic diseases. I'm Anna Douglas, Marketing and Communications Manager for Fujifilm Healthcare in Europe. Today, we will talk about how to improve the quality of your examination using a variety of probes and tools. I'm pleased to introduce Dr. Hironori Tanaka from Takarazuka City Hospital in Japan. Dr. Tanaka specializes in hepatobiliary and pancreatic use of ultrasound for detailed diagnosis and interventional procedures, such as ablation. In this webinar, he shows the advantages of each probe and applications with some interesting cases. Because this is a pre-recorded session, type your questions in the chat during the webinar. Dr. Tanaka's answers will be made available on the webinar microsite as of December 10th, and the link will be posted in the chat. After the webinar, you will receive a survey, so please fill it in because your feedback is very important to us. Before we watch Dr. Tanaka's webinar, let me provide you with some insights regarding our name change to Fujifilm Healthcare. In March 31st, 2021, so this year, Hitachi's diagnostic imaging business was successfully transferred to Fujifilm Corporation, and consequently, Fujifilm Healthcare Corporation started its operations. The new company will provide you with a one-stop solution by complementing and strengthening the imaging diagnostic businesses that grew from the medical fields and the wide range of medical businesses that Fujifilm has. All our customers and partners can now count on our people, our service, our promise, but now with new synergies. Fujifilm Group offers comprehensive solutions through the development of an extensive lineup of medical technology, including X-ray, mammography, ultrasound systems, and endoscopic instruments. Although the world has changed dramatically, we will not only respond to these changes, but we will change ourselves as well. Fujifilm Healthcare Corporation will generate new value for healthcare. So now let's watch Dr. Tanaka's with a voice-over translation.
My name is Hironori Tanaka from Takarazuka City Hospital in Japan. The new linear probe released this year and the new Microconvex released last year have been very good. So today, I'd like to talk about how to use them to perform ultrasound diagnosis of hepatobiliary and pancreatic diseases. First, let's take a look at the major probes currently used for abdominal examination and treatment. Four types are mainly used. They are normal convex, high-frequency convex, microconvex, and low-frequency linear. It is difficult to choose the right probe to use from such a variety. First of all, normal convex can be used to measure liver stiffness by elastography, so it is indispensable for the management of liver diseases. In some cases such as obese patients, it could be difficult to delineate the liver without this probe. In case of Asian patients like Japanese, the number of obese patients is relatively small, so I prefer to use high-frequency convex for normal screenings. For treatment, microconvex is very easy to use. And especially when you need to observe in detail, low-frequency linear is very effective. However, I think it is difficult for many facilities to have all of these four types. Therefore, I'd like to share my ideas on which probe to use by the purpose. You would need normal convex and microconvex at least. Normal convex is necessary to diagnose liver stiffness and fatty liver in abdominal examinations. And if one more probe is to be added, I would select microconvex, which is suitable for treatment. This C23, a microconvex probe for abdomen, was released last year, and its pursuit of image quality performance has resulted in a significant improvement in image quality. Not only treatment but also screening can be managed by this microconvex probe. Here is a comparison between this C23, conventional microconvex, and normal convex. The curvature is 25 degrees, which is gentler than conventional microconvex, and its field of view is 110 degrees, which is wider than the conventional one. The short axis width, thinness of the probe, reveals how slim is the probe as it is only 12 mm. And the type with the built-in position sensor for RVS is available as well. In this case of hemangioma, the lesion is clearly delineated from the proximal to the distal border, and almost no difference could be felt in image quality compared to a convex probe. I could even say its image quality is much higher than an earlier convex probe. This is a case of intrahepatic cholangiocarcinoma. A large hepatocellular carcinoma of about 8 cm in size is found in the right lobe of the liver. This patient has ascites and we need to consider its effect, but the mass in the bottom of image is well delineated. This is a branched IPMN in the tail of the pancreas. I was able to detect the continuity between the main pancreatic duct and the cystic lesion with both of these probes. Next, let me introduce a new function, wide scanning. Wide scanning is a function that provides a field of view equivalent to that of a regular convex probe by widening the view angle to 110 degrees, while minimizing image quality deterioration. As a result, this microconvex probe is not only light, but also very easy to handle. If it could be used in routine examinations without any discomfort, it would be very effective, especially for doctors who are not used to the use of ultrasound probes. This patient is a 73-year-old male, with multiple metastatic liver masses from a lung cancer in the right lobe of the liver. A round hypoechoic SOL with clear boundary is found with a convex probe. With wide scanning used, the field of view is almost the same as that of a normal convex probe, allowing observation with no discomfort. Even if you compare an image, using wide scanning with a microconvex probe, and a normal image, you can hardly point out the deterioration of image quality. In addition, the image using wide scanning with a microconvex probe has the comparable quality to that of convex. I think that there is no problem for the use in screenings. This is a case of hepatic hemangioma that was referred to our hospital for detailed examination, because a hepatic mass lesion was noted during CT scan screening at another hospital. A typical hepatic hemangioma with a 15 mm marginal strong echo is found in segment 8. With a convex probe, the entire lesion can be observed widely, but the intercostal lesions are rather difficult to be observed due to gas artifacts in the lungs. On the other hand, microconvex provides a better view of this lesion, and the complete picture can be observed. With wide scanning used, the field of view of convex is kept, and a lesion in the hepatic dome is well delineated. This is also a case of multiple hepatic masses pointed out in a medical checkup and referred to our hospital for a detailed examination. 4 hepatic hemangiomas are found in segment 7 to 8 of the right lobe of the liver. As in the previous case, it is somewhat difficult to delineate the lesions just below the dome with a convex probe. However, using microconvex, these lesions can be clearly delineated, and using wide scanning, the lesions under the dome can be easily delineated with the same coverage as observed with convex. This is a contrast-enhanced ultrasound image of the same case. Even with a microconvex probe, we can observe the spotted pattern and fill in of the hemangioma in the early stage of contrast in very high spatial resolution. One of the technologies that achieve the high image quality of C23 is the use of a single crystal on a microconvex probe. This has enabled us to obtain a solid signal to the depths, with high energy conversion efficiency. Acoustic pressure is one of the most important requirements for ultrasound imaging. Conventional microconvex probes, including those of other companies, could not raise MI to above 1 because they heated up when the radiated acoustic pressure was increased. The new microconvex probe has improved its heat dissipation capability by reviewing the heat dissipation design and can output nearly twice the sound pressure of a conventional type, or the same as that of a normal convex. This has enabled us to obtain strong harmonic signals to the depths and maintain high resolution from near to far field, which was difficult with a conventional microconvex. The cable is light and easy to handle, and the shape is very comfortable to hold. In this microconvex image, the liver parenchyma can be observed homogeneously from near to far field, and the mass is well delineated. We'd like to show you the image quality of contrast-enhanced ultrasound with the new microconvex probe as well. When arterial phase is observed with definition PI, the dynamics of the contrast medium can be observed in very high spatial and time resolution. This is an image of portal phase, and you can clearly tell that the lesion is hypoechoic. This is an image of portal phase. This is 1 minute and 44 seconds later, but when observed with definition PI, the portal and hepatic venous blood flows are still clearly delineated. Kupfer phase can be observed most sensitively and stably by AM method. But definition PI allows observation with even higher spatial resolution. Next, I've checked how much puncture needle visibility this new microconvex probe can provide. This is an image of a liver biopsy using a 16-gauge liver biopsy needle. This is a case of primary biliary cholangitis, but the needle can be observed clearly during procedure. No bleeding was found after the puncture. This is a case of metastatic liver cancer. 21-gauge aspiration biopsy needle is used. Although the puncture angle is close to the ultrasound beam line, the needle visibility is very good in this case as well. Let me introduce BX2 needle guide, which was developed with this new microconvex probe as well. This is a disposable type designed to prevent infection. It is designed to be attached to the probe over the probe cover, so there is no deterioration in image quality due to wrinkles. Furthermore, it is all-in-one structure integrating the needle guide and mounting part to avoid instability due to complex configuration. In addition, it fits the probe and does not interfere probe handling. These are dedicated attachments for this needle guide. Only two types of fixed puncture angles, 5 and 25 degrees, are available. So, it is required to change the attachment depending on the puncture target. However, a microconvex probe can be tilted widely due to its small curvature, so the structure of needle guide would not be a problem in most cases. Here is an image using this new needle guide. In a patient with gallbladder cancer after surgery, recurrence was suspected at the anastomotic site. So, we first tried drainage using a double balloon endoscopy. However, the bile duct in the right lobe of the liver was not contrasted, and PTCD was performed. As you can see, the image is not deteriorated even under the probe cover. I performed peritoneal anesthesia, but when I used 25-degree biopsy angle under wide scanning, I did not feel blind area. It is a movie of actual puncture with a 21-gauge PTCD needle. The portal vein was running in parallel on the right side of the image, so I punctured targeting a little left side of the image. No blind area is found, and the needle tip can be followed clearly. I come back to the photos of probes for abdominal examinations from the introduction of Microconvex. I propose one more combination of probes. For example, low-frequency linear can be used for a detailed examination of lesion pointed out with convex. I'd definitely like to prepare this probe, because the highest spatial resolution can be expected. From here, I'll introduce L35 linear probe for abdominal region, which is available from this year. What is required for a linear probe for the abdomen is high spatial resolution for detailed examination of the lesions, noted by a convex probe. After screening, a linear probe is used to evaluate the area that needs to be observed in more detail. Typical examples are adenomyomatosis and polyps in the gallbladder base, masses in the pancreatic body, and small masses on the liver surface. In actual use, we switch from convex to linear for observation. In order to delineate a target, it is sometimes difficult to judge where you are observing if just shallow areas are imaged. However, if it is possible to delineate deep areas, it is easy to reproduce the areas delineated by a convex probe, based on the shape of the surrounding structures such as blood vessels. In this respect, even with a linear probe, deep abdominal imaging is desirable. L35 is a linear probe that meets these objectives. Then, I'll show you some clinical images with L35. First is a case of gallbladder lesion. This case is a 10 mm hyperplastic polyp at the base of the gallbladder. The size of the polyp was increasing after it was pointed out at a medical checkup, so the patient underwent cholecystectomy. It is somewhat difficult to delineate with a convex probe, due to artifacts caused by multiple reflections, but clearly visualized with linear. Blood flow can be observed in detail. Directionality by color Doppler, blood flow continuity by DFI, and dense stain of the entire tumor by contrast-enhanced US. Next is a gallbladder adenomyomatosis. In this case as well, when the lesion at the base of the gallbladder, which had been found with a convex probe, was observed in detail with a linear probe, microcysts for RAS diagnosis were well delineated. By using contrast-enhanced US, the contrast resolution is further improved and the RAS is easier to identify. Next are pancreatic lesions. This is a cystic tumor of the pancreatic body. The patient was referred to our hospital for a detailed examination of a pancreatic cystic lesion pointed out in a medical checkup, but due to decreased renal function, contrast-enhanced US was performed. Although a nodule was noted inside the cystic lesion with a convex probe, its detailed internal structure is difficult to determine. A linear probe image also shows a cyst-like structure inside the nodule. Contrast-enhanced US revealed that what we had thought as a nodal area was a microcystic lesion. This was a finding suspected as a macrocystic type of serous cystic tumor, rather than IPMN. Next, let's check hepatic tumors. This is a case of hepatic metastasis of a 9 mm lung adenocarcinoma located at segment 5, on the liver surface. Although it is a small metastasis, we could point out a lesion with a convex probe. The same level of observation is possible with a microconvex probe. The contours can be observed the most clearly with a linear probe. The internal structure can be observed clearly with a linear probe as well. We observed this case with contrast-enhanced US. Even in small nodules, we can observe changes in blood flow, in other words, early staining and washout. The sensitivity is good in portal phase as well. In Kupfer phase, the nodule is clearly detected in both PI and AM methods. AM method is slightly more sensitive. This nodule was punctured in contrast mode. A fundamental image is on the left side of the screen in monitor mode, and the evaluation in combination with a contrast image is effective for a presence diagnosis as well. The visibility of the RFA needle is good even under contrast. In the upper right movie after the start of the treatment, we can observe the spread of the bubble. The bubble spread is an artifact as well, and is delineated on fundamental mode, but is difficult to check in contrast mode. I think the combined use of modes is one of methods to observe the bubble. The lower right image shows the end of treatment. Let me introduce L35 again. L35 is a linear probe with improved sensitivity in the low frequency range. It has a 45 mm wide field of view, and is designed for easy operation. Versa attachments can be attached directly to the probe. In addition, marking assist can display lines, corresponding to scales on the probe surface in B mode. This graph shows the frequency bandwidth and sensitivity of a currently used convex probe and a high-frequency convex probe. It may be slightly less sensitive, but by extending the frequency band to a higher point, a higher spatial resolution can be expected. On the other hand, a conventional linear probe was designed for a higher frequency range. It is inevitable that sensitivity decreases as the frequency increases, but sometime, for example in abdominal cases, it is necessary to visualize to far field. So, L35 shifted its frequency bandwidth to lower frequency side. The sensitivity of the probe is also improved by using a single crystal. This allows for high visibility and penetration to capture minute changes. The probe is widely applicable to abdomen, lower extremity veins, and carotid arteries. This slide shows another element that achieved the goal of a linear probe for abdominal examination. We have adopted a matrix structure in which the transducers are divided and arranged in the direction of the short axis, that is, the thickness of the probe. This matrix structure allows for optimal image rendering according to depth. It is designed to optimize the beam width according to the depth. This makes it possible to select the optimal short axis aperture according to the depth, and thus to produce images suitable for each region. This is the reason why this probe has succeeded in achieving high image quality. DFI, detective flow imaging, has also been further evolved in a linear probe. This is an image published in 2019, 2 years ago. You can check the micro blood flow in flash and capture. When we observe this lesion with DFI, we can capture the blood flow in the tumor. If you use DFI in contrast mode, you can capture very fine blood flows. However, the DFI as of 2 years ago is a bit noisy. The blood vessel continuity is also a little inadequate compared to the current one. This is a case of small hepatocellular carcinoma observed by a new linear probe. This patient is to take the 5th RFA. The lesion can be observed as a hyperechoic nodule when observed with a high-frequency convex probe. The boundaries of the lesion can be observed more clearly with a linear probe. And DFI has almost no flash noise compared to the one of 2 years ago. Moreover, the fine low-velocity blood flow is delineated with high continuity. I was surprised by this. I'll present one more case. This is a 77-year-old man with multiple liver metastases from a bladder cancer. Numerous SOLs can be found in the entire liver. When observed by DFI, blood flow can be observed with high continuity. If contrast harmonic imaging is used, even finer blood flow can be evaluated. When this case of multiple liver metastases from bladder cancer is observed with a convex probe, irregular wall thickening of the entire bladder wall is observed. When we observe this with E-flow, we can tell the directionality of the blood flow, but the continuity of the signal is insufficient. However, with DFI, fine blood flow can be observed in detail with high continuity. When contrast mode is used, it gets possible to evaluate the amount of blood flow in the tumor. When DFI is used in contrast mode, it is even more sensitive, and with flash and capture, even finer tumor blood vessels can be observed. Finally, let's take a look at the penetration of this new linear probe. High penetration is one of the appeal points of L35, so I'd like to show a case of liver cancer at 7 cm depth. This red line shows the depth of 7 cm. You can see the nodule. It can be observed with a high-frequency convex probe. If you look at it with color Doppler, E-flow, and especially with new DFI, you can observe very fine blood vessels that cannot be found with other modes. In this image, we are observing the same case with a linear probe, and even with a linear probe, we can observe well up to 7 to 8 centimeters. With DFI, we can observe fine vessels. Its continuity is further strengthened by using accumulation. I think you can clearly check how the blood vessels flow into the tumor. It is possible to observe at least to 8 centimeters depth with L35. Penetration is very good in contrast mode as well. The arterial phase is well contrasted at 7 to 8 centimeters, and hypoechoic lesion is observed in portal phase. I think it is amazing that we can check so much with a linear probe. Let me introduce one more case. When observing with a linear probe, we can observe very deep area, 8 to 10 centimeters in this case. We could say it is possible to observe clearly up to 8 centimeters with all methods. As I mentioned today, variety of probes are available for abdominal examinations, but it would be difficult for many facilities to have all of them. However, as I mentioned earlier, microconvex and linear probes are now available with better performance than ever before, so I think it is possible to select the most suitable probe according to the needs of the facility. This is the summary of my presentation. The innovation of heat dissipation technology has made it possible to achieve an output as high as Mi 1.6, which was previously impossible with a microconvex probe. The new microconvex probe can provide almost the same image quality as a convex probe, and can be used for both screening and treatment. The new linear probe can be used to observe lesions as small as 8 centimeters with extremely high spatial resolution, and in combination with DFI, it is possible to evaluate blood flow in detail even without contrast. Thank you very much for your attention.